So I'll be talking about at least a hypothesis of the pathophysiology of diabetic neuropathy in general and painful diabetic neuropathy in particular. If you sort of look up diabetic peripheral neuropathy, you'll see that there are essentially two competing reasons that this disease is, or this condition is ascribed to. One being a metabolic origin, namely due to the many episodes of elevated blood glucose, and another is a macrovessel or microvessel alteration, so a vascular hypothesis. So I'll try to give you an overview why these two different reasons have been competing in the past, but also how we may reconcile these as essentially being indicative of the same underlying mechanisms. So the reason for considering microvascular changes is, of course, that they are easily visible if you look at nerve fibers or the vessels of nerve fibers from diabetic animals and humans. And the reason for microvascular problems, of course, giving rise to reduced nerve conduction velocity and to symptoms would be that ultimately blood flow would be so low that there wouldn't be sufficient ATP for neuronal signaling. This hypothesis ran into a problem, and it's the one you see here, namely that blood flow was measured in early diabetic patients, in controls, and in patients with diabetic neuropathy. And you would expect that diabetic patients who were later going to get diabetic neuropathy would sort of have a reduced blood flow if a vascular problem was sort of at the heart of the pathogenesis. But instead, it turned out that blood flow was increased in early diabetic patients as opposed to reduced. And you could also see patients who actually had developed symptoms who had sort of a normal blood flow, and that doesn't really sort of match well with our understanding of textbook physiology. You would expect there to be a reduced flow for vascular problems to be the cause. I'm going to try to explain to you why the textbooks have in fact been wrong, and why an elevated blood flow actually can be indicative of a vascular problem. So understand that we're going to go back almost 100 years in time and look at where our sort of concepts of the relation between blood flow and oxygen supply to tissue comes from. Originates from these two brilliant Danes who looked at single capillaries and observed how substances such as oxygen could be extracted from individual capillaries. So they looked at single capillaries, they looked at the velocity of blood and hence how much blood passed through the capillary per unit time. And so there was this relation between flow velocity and then how much, in this case, oxygen could be extracted. You can see that's a nice increasing curve, so it means the higher the velocity, the more oxygen is available. What later happened was that someone needed to develop this into a formula for tissue. So we could find out, for instance, in a nerve, how much blood flow does it require to have a given oxygenation or a given metabolism in the nerve ending. And for that purpose, these gentlemen sort of generalized the equation or the curve you saw just before. And what they did to do that was that they assumed that all capillaries in tissue have identical velocities, so blood travels at identical velocities. And you could simply multiply that equation from before with, say, 1 trillion capillaries, and then you would have the oxygenation of tissue. And of course this curve has some nice properties. It increases, and it has a one-to-one correspondence between blood flow and oxygenation. So we can rest assured that if we observe normal perfusion in a nerve, then there's normal oxygen availability. And that's why these findings you saw before in the nerve endings were so critical, because that would imply that because there was normal flow, there ought to be normal oxygenation. And also that for oxygen availability to be reduced, you'd need to see reduced perfusion, but they didn't see that in those nerves. I'll try to explain to you why this curve is actually wrong. As I said, they made this assumption that all capillaries in tissue have identical velocities. In fact, in normal tissue, and this is based on recordings of velocities in this case in the brain, but they would look the same in the peripheral nerve. Blood flow has very different velocities among different capillaries, and what that does is that some blood can actually travel through tissue and through the capillary bed very fast and simply not have time to deliver their oxygen to tissue. You can see indicated here how changes in blood viscosity, for instance, if you have an infection and activated endothelium, then these relatively large blood cells compared to the diameter of the capillaries can actually slow down blood flow. So it would be expected that these velocities are very different. And in this thought experiment, I've tried to indicate what happened if, instead of all being identical, half of the capillaries would have a very low flow velocities and the other a larger one, but such that the average flow velocity was still the same as in this condition. And what you can see by forming the average of these capillaries and these capillaries is that every time you disturb the distribution of capillary flows as it is in normal tissue, you reduce oxygen extraction efficacy. So every time you disturb capillary flows, there's less oxygen available. That's very important because it means that, for instance, if capillaries are damaged, if edema compresses without stopping capillaries, it also reduces oxygenation and so forth. And all of this happens even though blood flow is not hindered. So what does tissue do if all of a sudden the extraction of oxygen is not as good? Here we need to remember that the amount of oxygen tissue has available to it is the product of its blood flow and the extraction fraction or the extraction efficacy, meaning how many percent of the oxygen can actually be extracted. So what we were looking at before is sort of the classical, or what was assumed, namely that the microvessel alterations that occur in diabetes would somehow restrict flow and therefore blood flow would be lower. And we also know since the nerve will still be using oxygen, then the extraction fraction would go up. What they overlooked and what we've been overlooking up until now is that capillaries matter. So if there's a change in capillary morphology or function, then the oxygen extraction will not be as good. And because the vasculature is equipped with flow metabolism coupling, so if there's a need for oxygen, for instance, it will adjust blood flow to compensate for that. Then of course, with poorer extraction, tissue can increase blood flow to compensate for that. So notice how the finding of increased blood flow in early diabetic patients is consistent with the capillary dysfunction, but not with one that restricts flow in the upstream resistance vessels. So this phenomenon, and I showed, I think in one of the previous slides here, how we quantify these capillary flow disturbances with a number, so essentially the standard deviation of flows or transit times here. So the more disordered, the higher this CTH parameter. If it becomes worse, you can see here, this is the equation, the flow diffusion equation, the one that's in our textbooks. And these lines are what increasing disorder in the capillary flows does to it. So the oxygenation is much lower for a given flow than we would expect, simply because of this functional shunting, if you will, that some blood and its oxygen escapes the microvasculature. So the higher that is, the lower the oxygenation. And what is very important is that it can become so severe that it no longer helps to increase blood flow, as you can see here. We call that malignant transit time heterogeneity. Here, there's severe tissue hypoxia, but if we increase blood flow in this condition, hypoxia will actually become even worse. So that's not a phenomenon we know of, have thought of before. So just to summarize what happens if you gradually disturb capillary flows. First, as I said, the early stage in what was indeed observed is that oxygen extraction efficacy will go down, so the tissue will adjust by increased blood flow. In the end, that fails as a mechanism, and instead you have to start suppressing flow responses and blood flow in order to extract more efficiently. And in the end, the oxygen availability is gonna be so severe that there's simply not enough oxygen around to fuel the ATP needs of the tissue. So as I write here, if these capillary changes don't stop, then ultimately there'll be so little oxygen around that the nerve, in this case, will lose trophic support. And note that what this means is that you can have hypoxia in tissue without having what we know as ischemia. So are there signs of capillary dysfunction in diabetic neuropathy? There are early studies showing that actually the severity of the disease correlates with early pericyte. These are the contractile cells around the capillaries and the basement membrane in the capillary wall, so you can imagine how they could disturb capillary flows. Also, there's early hyperemia before you develop symptoms. That's when tissue can still compensate. You also see this paradox how symptom relief can occur when you reduce flow, for instance, by cooling the skin. And then what is very characteristic of capillary dysfunction is that changes in blood viscosity can affect disease severity. So for instance, something like hyperlipidemia. You can see here how infections where you have activation of white blood cells will make symptoms worse. Very briefly, I'll try and go back to the metabolic hypothesis of diabetic neuropathy. It turns out that these capillary changes do not only affect the extraction of oxygen, but also that of glucose. I don't have time to go into that, but it turns out that oxygen extraction is more affected than that of glucose. So there's a few very important take-homes from that, namely that if you, because of hypertension, age and so forth, hypercholesterolemia, develop capillary flow changes around your body, then that's going to affect your ability to take up oxygen and glucose. That's what I show here, that capillary dysfunction will also reduce glucose uptake. That will tend to give you hyperglycemic episodes as glucose then backs up in your systemic circulation, giving rise to oxidative damage, which again can damage your microvessels. So this also raises the question, is type 2 diabetes, for instance, the end effect of capillary dysfunction? The other important thing to remember is that if this is the case, then your peripheral nerves the capillaries there may already be damaged by the time you develop symptoms of diabetes. And that's actually seen in animal models, that you have signs of diabetic neuropathy before you develop overt diabetes. And this ratio issue, namely that oxygen is more affected by glucose, that means that tissue will tend to develop lactate instead of doing complete breakdown or efficient breakdown of glucose. Another characteristic metabolic pathway that's elicited in diabetes is the aldose reductase pathway, and that is known to be a source of nerve injury in the disease, and again belongs to this metabolic theory. And I just want to point out that if you go over how would a nerve generate enough ATP to support its function, then it's left, of course, if it has enough oxygen, it can do it very efficiently by burning glucose by oxidative phosphorylation. Otherwise, it's by the effect I showed you before. It'll have to do, it should say aerobic glycolysis, but there it only gets 2 ATP per glucose. So that means that when both oxygen and glucose uptake in tissue is hindered, then it actually makes a lot of sense that tissue would in fact adapt to use this polyol pathway or the aldose reductase pathway in order to still efficiently generate ATP, even though it comes at the expense of oxidative stress. So, of course, this is also important, because does that mean that you're really hindering nerve metabolism if you then give aldose reductase inhibitors to patients? So just to summarize, to go back to what we saw in the very beginning, first there's the $50 million questions, and I'm so sad to disappoint you that it's only one line, but the origin of the pains in diabetic neuropathy, what we're exploring now is whether these metabolic correlates, namely the presence of hypoxia, lactate, and low pH, can be the cause of pain. But going back to these definitions, I hope I've convinced you that the interactions between these may actually have a common denominator or have capillary dysfunction as a missing link in our understanding of the etiology of diabetic neuropathy and perhaps even of type 2 diabetes. So with that, I want to thank my good collaborators and point you to this paper where we discuss this theory more, and acknowledge the IDNC grant given to Aarhus University. Thank you so much.
Thank you very much, Leif, for this interesting presentation. Setting the scene here with asking questions about pathophysiology, and you can't answer that. But any questions from the audience? You have your app, and it's possible to come up with a question to Leif Ostergaard. Maybe you have the solution for the pathophysiology. We have one question here. Please state your name.
Michael Schäfer from Berlin. Do you have an explanation then why we mainly see it in the feet, in the legs?
That's a very, very good question. I sort of bristled the idea of edema and the fact that you know, there's more capillary compression, of course, in the more distal parts of our limbs. But I don't have a really good explanation for why it's distal and why it's symmetrical. I know from experience with my own plumbing in the house that it would make sense that the most distal parts, they sort of are affected first, but I'm sure that doesn't apply here. It's a very good question, thanks.